Telestroke, an added value to emergency medicine? Hi, my name is Gregory Garra, and I wish to thank my co-authors, Shona Elliott and Gabrielle Garra, for their participation in this project. The use of telemedicine in patients presenting with acute stroke is becoming more commonplace. Telestroke is the use of interactive video conferencing technologies, specifically for the treatment of patients with acute stroke. A telestroke service is designed to augment local services that are not immediately available by leveraging remote expertise and resources. A telestroke service also permits standardization of stroke processes, both between providers and between institutions. Improvement in stroke-related processes using telemedicine has provided mixed results. The goal of this study is to compare stroke-related processes before and after telestroke implementation and investigate telestroke performance over time. Our hypothesis was that telestroke service would not significantly change stroke performance metrics or guideline compliance. This was a secondary analysis of a prospective observational consecutive sample cohort from a single tertiary hospital over 3 years. Telestroke services were implemented in July 2015 and utilized for emergent neurologic consultation in patients eligible for treatment with intravenous alteplase, TPA. Prior to July 2015, consultation with neurology for acute stroke patients was via telephone or in-person consultation. For each stroke activation at our facility, stroke performance metrics are abstracted and reported by a single program coordinator and includes, but is not limited to, demographic data, last known well, door to provider time, door to imaging completion, door to TPA bolus, and disposition information. We analyze performance metric and guideline compliance 6 months before telestroke implementation, pre-TS, 5 months after telestroke, post-TS, and a longitudinal component of 2 full calendar years after telestroke was implemented. Mean times in minutes were compared using t-test. Proportions were compared using Fisher's exact test. The pre-telestroke mean times were compared to post-telestroke, year 1 and year 2 groups using ANOVA. There were 95 stroke activations pre-telestroke, 96 post-telestroke, 228 in year 1, and 246 in year 2. Baseline demographic data were not significantly different between study periods. The mean door-to-provider times are listed and were not significantly different during the various time periods. The mean door-to-imaging completion times are listed. There was a significant difference in mean door-to-imaging completion between all post-telestroke time periods and pre-telestroke. The mean door-to-needle times are listed, and there was a significant difference in door-to-needle times between the pre-telestroke and post-telestroke group, as well as between year 1 and year 2 and the post-telestroke group. This line chart reflects the change in mean door-to-provider time, door-to-imaging completion, and door-to-needle times across the continuum of 3 years. With the exception of door-to-imaging, stroke performance metrics never exceeded metrics demonstrated in the pre-telestroke group. Compliance with the American Heart Association's Get With the Guidelines program are listed. There is no significant difference in door-to-provider or door-to-needle compliance between pre-telestroke and all post-telestroke time periods combined. However, there was a significant difference in door-to-imaging completion between pre-telestroke and all post-telestroke time periods. This line chart demonstrates the change in Get With the Guidelines compliance over the continuum of the study. There were a number of limitations to this study. First, the pre-telestroke sample size was small. Second, there was a specific focus on stroke operations and metrics that was implemented in June 2015 and is reflected in the improved door-to-imaging times. Third, there was a higher proportion of patients receiving TPA post-telestroke. We noted that 10% of pre-telestroke stroke activations received TPA, whereas 30% of stroke activations in the post-telestroke group received TPA. In conclusion, the introduction of telestroke services did not significantly improve stroke performance metrics or guideline compliance. Thank you very much.